Good afternoon, everybody. My name's Sue Scheinflag. I'm the Chair of Health Translation Queensland. Welcome to our webinar. I'd like to first, before we begin, acknowledge the traditional owners of the lands on which HTQ is based, and that's the Turrbal and Yagara peoples, and that's in the lands of the Meanjin in Brisbane. I'd like to extend that respect to all traditional owners across Australia, as well as any First Nations people who are joining us today in the webinar. I pay my respects to the First Nations ancestors, their descendants, who continue cultural and spiritual connections to country. These lands have always been places of teaching, learning, research, and collaboration. Again, a really warm welcome to our webinar today. The focus of today's session is to explore how new research methods, advanced analytics, and technological innovations are reshaping health and economic evaluation, and in turn, reshaping policy. We've got a bit of a powerhouse team today, so really interested to hear from Luke and Stephen and Joshua, and Jean is our facilitator and chair of today's session. So I'll introduce Jean and then hand over to Jean to get us cracking. So Jean is the Associate Professor at the Uni of Queensland. She's belongs to the Centre of Business and Economics of Health, where she contributes to the Evolve Health Program. That's one of UQ's strategic health research accelerator initiatives, which aims to redefine the future of work in the Australian healthcare sector. Jean has a strong translational background and experience as a health practitioner. Her work focuses on primary care challenges, including needs-based workforce planning, culturally appropriate, accessible care, and quality improvement in digital innovation. Welcome, Jean, and welcome, Luke, Stephen, and Josh. I'm really interested to hear from you all today. Thank you.
Thanks so much, Sue, and great to have you all along today. It really is the Queensland chapter of the Health Economics Family Christmas today. So we were commenting before that it's not often that we are getting our health economists from the major groups in Queensland all together at once. So welcome all. It's fantastic to have you along. So we've got three great speakers today covering on different parts of health economics. I mean, sometimes I think we automatically think about health economics as being economic evaluation, and it's great to actually remind ourselves that health economics is quite a broad discipline and then has reach into a lot of areas in health that we all work in as well. So it's important that we understand what each other does, that we can speak a similar language, or at least have a translator available for us when we're actually engaging between health economists and other trialists and other people undertaking work in the area. So without any more ado, I'm going to introduce our first speaker. So it's Professor Luke Connelly from University of Queensland. So he's a fellow stablemate in the Centre for Business and Economics of Health. Luke's work focuses on insurance economics and a particular interest in institutional and legal frameworks that shape incentive and behaviour. Luke served on several important public committees, including MSAC, so the Medical Services Advisory Committee, which has a direct impact on funding decisions by the Australian government in terms of health services in Australia. Today, Luke is actually going to talk to us, give us some broad brushstrokes about health expenditure and what drives health expenditure. So I'll hand over to you. Thanks, Luke.
Thanks, Jean. I decided not to do anything particularly technical today, but to give you an overview of what economists now know are the drivers of health expenditure. And they're the things that we all hear about, especially the ageing of the population is one that we hear a lot about. But actually, so there are basically four drivers of health expenditure. The ageing of the population is one. The widespread availability of insurance, including public subsidies in Australia, is another. The bulk of healthcare expenditure is really driven by medical technology changes. So these are innovations in treatments and in drugs and medical devices, for example. So you can see that since the 60s, coming off a fairly low base of health expenditure, this is expenditure via GDP, as a proportion of GDP, we're sitting down around 5% or so back in the mid 60s, and that the US has streaked ahead, and that number is up close
Luke,
enough.
I think, can I just interrupt? I think we're not seeing your slides. We're not seeing we're not seeing you in presenter mode.
I'll give up sharing mine and let HTQs share their copy of my slides.
That'd be great. Thanks. And I should say, if anyone has like burning questions while we're going through the presentations, we'll take short questions along the way, but we're going to wait for substantial questions at the end of the session. There we go, Luke. Back to you.
Right. Okay. So, yeah, can we go to the next slide, please? Okay, yeah. So I was just saying that health expenditure has been increasing as a share of GDP, and that was the fourth driver that I haven't yet mentioned, is that as incomes have risen, health expenditure has risen. But technically, in the way that economists classify goods, we'd say that healthcare is a luxury because we spend more as a proportion of our incomes as incomes rise. So it's not just holding a constant part of our GDP, it's a growing part of the GDP as well. Next slide, please. Okay, and we'll skip this one. We'll go into the next one, please. Yeah, and so you can see here a table of life expectancies for the top 10 OECD countries. You can see that despite us not having anywhere near the highest health expenditure as a proportion of GDP, we do quite well overall on non-Indigenous health for males and females, with some of the longest life expectancies in the world. And unfortunately, the Aboriginal and Torres Strait Islander life expectancies that we have there are some 10 years below those of non-Indigenous Australians. Next slide, please. Okay, we can see also that health expenditure over time is growing on a per capita basis as well. So between 2015 and 2023, there was about a 14% growth in health expenditure per person in Australia, and about a 19%, almost 20% growth in the States. Next slide, please. Okay, so here you can see the fact that actually Australia has managed to dampen the growth of health expenditure in recent decades. So since 2015, we've kept the share of GDP being used for health, having, GDP has obviously risen over this time as well, but you can see that the share of GDP that the health expenditure takes now in Australia is around 10% and has been for a number of years. Next slide, please. Okay, next slide, please. Okay, and so here's the first driver I mentioned, which is the aging of the population. You can see the difference in the age structures at 1973 and last year. So we've gone from about 45% of the population being under 25 in 73 up to down to 30% in 2025, while the share of people over 65 and people 65 and over has doubled from 9% to 18%. Next slide, please. Okay, so one of the drivers of this is obviously all of us value access to cheap healthcare and adequate private and social health insurance. But the problem with this is, from an economic viewpoint, is that it causes what we refer to as moral hazard, which doesn't actually have any real moral connotations. It just simply means that when the price of a good drops, people will consume more of it. And the only problem with this is that people tend to consume more than they would if they were paying full price. Okay, so it's kind of a natural problem that you will have with health insurance, that you get some moral hazards. So this will drive expenditure up as well. And down the bottom here, we've just got a breakdown of the different sources of funding for the health sector, and the governments in Australia make up about 70%, and individuals make up about another 30%. Next slide, please. So if you think about this, sometimes international audiences are surprised when I tell them that it's cheaper to have a doctor come to your house within a 2-hour window than it is to get a cheap pizza from Pizza Hut, they're quite surprised that we don't charge anything for this service. And if you think about this, I think it's actually a little bit surprising that moral hazard isn't much worse in Australia, because even if you just think about the convenience of having a doctor come to your home rather than sitting in a clinic and usually waiting quite a long time, and having that free when the doctor is also taken there with a chaperone, it's a very expensive but very low cost service for those using it. Next slide, please. Okay, you can see we've had strong income growth over time, and as I said, not only while income grows do we keep spending a proportion, the same proportion on healthcare. We're spending more and more of our GDP as a proportion of our income as well. So it's increasing at a faster rate than income itself. Next slide, please. Okay, so there's a very old source of explanation of health expenditure growth from the Productivity Commission. It's a very good report, and they attribute the bulk of health expenditure growth, as does the international literature, to technological change in the health sector. And when you think about this, like while I've tried to separate these four sources, all of them work together, of course. So you've got new technologies coming into play, which are more costly. They're subsidised heavily through the Medicare system. Our income's growing, and we want more health and longer lives. And we've got an ageing population that also places larger demand on the use of these technologies. So you can see that when you look at the roles of, say, ageing, it's relatively small compared with the role of other types of increases in health price inflation and so on. Next slide, please. Okay, and that's all I'll say for the moment. Happy to answer questions and to explain how it is we actually measure some of those things, which is a bit more technical.
Thanks so much, Luke. We've had one question from Oliver, but I might actually hold off on that one for the whole panel at the end of the session. Are there any more questions of clarification at the moment for Luke? Just pop them into the Q&A if you've got questions going along. If not, we're going to jump over to Professor Josh Byrnes. So Josh is the head of the Centre of Applied Health Economics at Griffith University. Josh's research concentrates on the design and analysis of studies for the purpose of measuring and demonstrating value in health. He's the current president of the Australian Health Economics Society and past Australian president of the International Society for Pharmacoeconomics and Outcomes Research. He's significantly impacted and influenced policy, including in the areas of plain packaging tobacco legislation, pregnancy warning labels on alcohol, and opt-out arrangements for My Health Record. Josh is going to challenge us about the role of AI in health economics moving forward. Over to you, Josh.
Thanks, everyone. I'll start with the take-home messages up front. So we always looking to maximize value. So here are the benefits without the cost of having to wait to the end. But the key take-home here ultimately is that the fundamental purpose of economic evaluations is actually supporting transparent, structured decision-making that brings parties to understand the benefits, costs, and uncertainty. One of the kind of legacy sort of criticisms of economic evaluations is that it's a black box. You give the data to the health economist, he gives you results, no one knows what happened in between. The risk here is that AI can just be a bigger, fancier black box, which is the opposite of what we're actually trying to achieve. But fundamentally, AI has this real opportunity to reduce the cost of prediction, reduce the cost of being able to undertake economic evaluations. And here are the three that are kind of really sort of stepping up and being utilised quite a lot at the moment. The challenges I see are really challenges for economic evaluations in general, but the risk is that AI is going to sort of really exacerbate these. So the extent to which our economic evaluation can provide accuracy, reliability, transparency, validity, and the potential for unknown kind of risks of bias. A couple of journal articles there for you to kind of read. They kind of provide a nice overview of where we're at in the kind of landscape that we're dealing with. So let's take it back, look at the background. The kind of key fundamentals kind of informing where I'm coming from today. So economics is the science of choice. And in health, we make really difficult choices because we have unlimited wants and scarce resources. If we look at sort of some of the behavioral literature, so this is Thaler, author of Nudge, individuals make pretty bad decisions, especially if we engage in that kind of fast thinking and we don't think about it in terms of that slow, structured approach. So economic evaluation is really just a tool and a structured approach that's evidence-based, kind of bringing us to this kind of unifying goal of value, which is to maximize our health outcomes relative to these scarce health resources. But at the heart of kind of decision making is prediction. And that's really where I think AI is kind of obvious to sort of open up this kind of conversation. Looking at artificial intelligence, I'll just have one slide just as a real general. AI is all about connecting inputs with outputs. But instead of giving it a whole lot of rigid formulas and rules, AI is taught by millions of examples to kind of see how it can kind of connect those dots for outputs and inputs. When we think about some of that open source or generic AI that we're probably familiar with or using a lot of that's actually optimized for likes, whether or not the person gets something that they like or want, as opposed to something that's accurate in itself. And that's part of how AI is taught with this kind of idea of reinforcement learning. So it makes a prediction, it's then just told whether or not it's right or wrong, and then it goes away and redoes everything just to go back to this idea of, well, did I get it right or not? But if all we're doing is telling it's right when it's something we like, we have a bit of sort of mystery and sort of confusion. So that's sort of setting up our potential risks here in terms of using AI with economic evaluation. What I thought we could do is actually just go through the steps of an economic evaluation, and let's use ChatGPT along the way and see what it gives us. Let's just actually use ChatGPT here. It's free, it's online. It utilizes math packages, which is really great. So it's not predicting some of our calculations, it's actually estimating them for us, and see what we end up with. So the steps in an economic evaluation, really broadly here, a bit of a roadmap for us, is we define our decision. We're all about decisions and informing that decision problem. We kind of conceptualize our model ourselves in terms of thinking about, well, how do inputs influence consequences of our choice, and how does that relate over time? We then think about having to pick or use particular values for each of the variables in our model. We analyze it to estimate our results, typically something like an incremental cost effectiveness ratio, how much additional cost for additional benefit that we're getting. We then take a step back and look at other considerations that we're not explicitly modeling, and then we try and make an informed recommendation to kind of push along our decision. When thinking about defining a decision problem, I like the PICO STP. That's just something I've coined, but very much you'll see a lot of people kind of take some kind of, well-known PICO and then expand it to kind of think about our economics, with the PICO kind of being our population, intervention, comparator, and our outcome. Intervention and comparator are very important because it's a choice, and so we're always thinking about what we would have otherwise have done. We do need to sort of modify to think about our study design. So within trial, meaning that we can observe everything that we need, all the costs and consequences from a choice within one study, or we need to bring in multiple sources of data, or where we need to think about a time frame which is beyond what we've got data for, which brings up time frame. So we're thinking about the costs and consequences associated with our choice. So over what time frame are we going to follow up those consequences, that rippling out effect from our decision? And knowing that we've got a decision here, there are different decision makers and they all have different perspectives that they're going to bring to this choice. We can talk about a societal where we think about all sort of agents and sort of summing across them. We can think about a system, so just the health system in terms of what the cost and impact is for a health system. Or we can think about even more narrow in terms of a specific organisation. So Queensland Health, for example, will be thinking differently to the Commonwealth, which will be thinking a bit different to a system overall, which is kind of looking at the net. So how does AI do? So this blew me away a little bit. So the bold text is just simply what I put into ChatGPT. You can play along at home and pop that in yourself and see what you get. It actually produced a really nice about page and a half of script looking at each of the kind of elements of a decision. And I threw it an example here of an allied health-led hospital in the home program. And it actually went through each of those sort of elements. It thought about different kind of options that one could choose. It provided some justification and a bit of narrative around its choices. And then this is the summary paragraph that it produced. And I've just highlighted in terms of underlining the various elements that I asked for in that kind of overall decision problem definition. If I look at that as a health economist and an economist who's worked in a few of these areas, it's pretty much spot on, right? So in terms of what type of study did it choose for the hospital and the home program, it chose a trial base being a short time horizon. It chose a cost utility analysis. It's comparative with standard inpatient care. It's picked a health system perspective. It's using a 90-day time horizon, which is appropriate. Typically, when I've looked at these, the pushback from clinicians is that they want a shorter time horizon, 28-day time horizon in terms of looking at representations. Health outcomes are being measured, what resource use, the result that it's going to produce, and even looking at uncertainty. I then simply said, well, do the same for me, but for a new clinic that's going to look at diabetes and kidney disease management. And here, again, it was spot on in terms of what I would have otherwise chosen as those inputs for defining that decision. The issue, I guess, is I didn't have anything here, but if I did want to make any choices and changes, I was surprised how much kind of supporting evidence or narrative was around each of those that was provided. So it actually did a really good job. Surprisingly, I was surprised. When we think about that next step along the way, though, is model conceptualization. So here we're really trying to come up with a blueprint for our mathematical model to estimate our outcomes, our total kind of costs and our quality adjusted life years, so survival and quality of life over time. It's an interesting one because the literature is a bit scant here. I've provided a link for you in terms of something coming out of the Flinders group looking at how do we do this for a new health service, which takes a bit of that defining the problem into model conceptualization together. But it's a bit scant and it's very important because this is how we're going to articulate sort of how things are connected and linked over time and how we're actually going to calculate things. There's a whole range of different model structures, a whole host of different, generic approaches that we can use. The most common is this kind of Markov model, which is this one with the circles and the blue lines. In terms of how we conceptualize it, we've got to make decisions around all of those little health states to reflect what's going on, all the arrows in terms of that kind of causal pathway of how things are going to happen over time. If I look at the different types of models, I've listed them probably apart from partition survival analysis there in terms of going from very simple to very complex. When we start looking at individual simulation models, we're allowing individual patient characteristics to influence the risk of disease or future events occurring and costs. Dynamic transmission models are really used in infectious disease. So we're now looking at, well, what's the state of kind of infection in the population and how that may affect my risk of getting infected or a disease. And then we can think about discrete event simulations, which is stepping up again. And now we're starting to sort of actually put some units here of resources and scarcity around those. So we can actually look at the extent to which wait times and other sort of factors may be influenced. So if we're looking at vaccination as a classic, at the beginning, we may just not have enough vaccination for enough people. And so we can actually start to model that kind of decision within there and what that means when we run out of something. Or if we've only got one doctor and they can only see so many patients a day, we can actually start to model those things out. Agent-based modeling goes again a bit further and starts bringing in individual behavioral kind of choices within our model, getting much more complex. So I asked the AI ChatGPT, throw me a decision tree for this hospital and the home program, and this is what it gave me. I did have to specifically ask it to consider escalation. So this kind of idea of transfers back to the ED when someone's on a hospital and the home program. I spent a bit of time making this prettier, but it did a pretty good job in terms of how I would otherwise structure this out in terms of an analysis, sort of thinking about these final no readmissions, some kind of readmission in the follow-up period or death as our kind of final end states. In terms of the Markov model, so I asked it, okay, provide me the Markov model for this diabetes and end-stage kidney disease model, new clinic. It was a lot uglier. And here we started to see it was starting to make a lot of assumptions, although it provided some justifications, which really started testing whether or not I'd be anywhere near relying on this in terms of anything. So if we're looking at a diabetic population, for example, we've got a simple one-way kind of transition from controlled HbA1c, for example, to uncontrolled. but we don't have an arrow back. So there's no way of moving someone from an uncontrolled HbA1c back into being controlled. So already it's starting to make some assumptions and predictions around our things, which as a health economist, I'm starting to pick up and go, well, this is a bit strange. I then asked it to include hospitalizations as a transition event. It didn't really understand what I was doing, and it just changed this complications health state here to hospitalized. And all the lines were a bit funny and hard to actually understand what it meant. The next part of fair and economic evaluation is actually picking values that we're going to put into this model to then run our calculation. And this is going to be heavily dependent on the data that's available. And we often have to make a lot of transformations and transitions from that data to be able to be used in our kind of economic model. So I just asked ChatGPT, provide me with these parameter values with plausible ranges, and then a few extra commands to get something out. I got a table that would be pretty much ready to go into a publication, but this is where I started to see ChatGPT not being the best, and it isn't the best for kind of literature reviews and data synthesis, and that's kind of known, if you like. But it's starting to become a bit cheap in terms of once it found one particular publication, it then hit the same publication for all parameters. When I started looking at what it actually started drawing out from the literature, these weren't really exactly what I was after. It was their kind of best guess at what it was, but it gave values, and it wasn't terrible. It just wasn't spot on, if you like. In terms of our diabetes CKD clinic, again, I just asked for a table for this Markov model. It did a slightly less well job in terms of being able to provide sources and actual data for things, made a few more assumptions, but the assumptions in general weren't terrible. So if we look at where it's able to sort of source the PBAC guidelines for a discount rate, for example, it was spot on. Some of these other things, when I started dropping in and finding out what's actually trying to be included here, it was a lot more vague. But it did a really good job in terms of picking the distribution or the statistical distribution around a parameter, which was actually quite surprising and quite interesting. And it was very quick. We're talking about doing this in the matter of 6-7 minutes. So if you're playing along, you'd be up to where I am. The next stage, we look at analyzing it and sort of being able to use our model to now calculate something for us that's of interest, our incremental cost, our value kind of estimate. People do this in different software, Excel, Triage, and then obviously some stats packages like R and Stata. Typically, it's always an iterative process to debug along the way. And then we do some validity testing at the back end to make sure how well are we going. So that's our traditional approach. I asked AI to do the same, and it was quite interesting. So I actually asked it to produce the Stata code, so the code so I could actually run the analysis. And it provided some pretty good code, but it took me about 46 attempts going back and forth with ChatGPT to actually solve some of the bugs that it was throwing me. It required me to force, so I'd kind of forgotten about the fact that I wanted a decision tree. I'd forgotten kind of some of the estimates, and I was taking some shortcuts. So it's really trying to be as quick as it could. So I had to force it. But I understand that Stata is probably not the natural language you want to be talking with ChatGPT or any kind of AI in general. Python or R would have been better. When I look at some of the estimates it started to throw out just in terms of results, it's really nice here in terms of it produced the cost effectiveness plane where we can kind of look at sampling different values within the range of any given input on our quality adjusted life years here down the bottom and our costs up here. But you can already see something's really going wrong. So our additional cost here is 50 cents. That's just crazy. It doesn't even relate to our kind of estimates that it was trying to provide. Our quality adjusted life years here, it's got them at ranging from 2,000 to losing 2,000. Again, not reflecting the estimates. When I start looking at the ISA and the estimates that it's using, it's made a whole lot of errors in terms of those input parameters and what they actually are. So one of the ones that was easily to identify was instead of using 0.8, it used 80 in the code. So it was starting to really struggle in terms of keeping up with itself. The Markov model produced really nice code. Again, lots of errors, and you can see them here when we start looking at our results in terms of these things just don't make sense. These numbers aren't adding up. The code to run it was okay. It lost some of the complexity around complications and other things. But again, it's just fallen off. The wheels have completely fallen off. So this P25 is meant to be our kind of 95% credible interval. So this is where 2.5% of our predictions fall. It's equal to the mean. Again, wheels have just come off. I then kind of thought about these other considerations of our economic evaluation and our decision maker. I just simply asked AI for the HIF model, provide me some summary of these other things that a decision maker may be interested in. And it actually did a really good job of identifying issues and providing a narrative around each of these things which may be of interest to a decision maker. So it actually did a good job around the narrative sort of stuff. Okay, so greater application in the future. So obviously the examples are above are based on an open, free, quick, free, dirty kind of approach. It surprised me in terms of how good it provided insights along the way, not an answer, but consideration of assumptions, addition, approaches. It did produce code that I could then use. It just had a lot of bugs. I did both of those evaluations in about 2 hours. So we're talking about going from, weeks down to about 2 hours in total though. Areas that I know are better AI are out there that wasn't used here, obviously, is there's a lot of nice AI already in terms of systematically reviews data extraction and meta-analysis. Nice stuff for about analysis in general and integration of organization data or administrative data to produce estimates, which we didn't really, utilize here. How do I see it in the future? Much more complex system and agent-based models. So if we can do these simple models in an hour or two based on some code out of AI, we're already seeing more complex models being introduced in terms of what we see in terms of going up for funding requests. I'd say this is only going to push for more complexity, just as a natural, if it's cheaper and easier. I think there'll be more AI packages that might be trained specifically for economic evaluation start to come out. And I think the integration of AI in terms of economic evaluation with organizational data is where it's probably likely to head, which is trained internally and specific. And obviously, there's going to be a need for everyone to be upskilled in AI and use of it potentially, but more so in terms of the interrogation of AI outputs and how we actually analyze and evaluate for validity. So in summary, yes, we can. We've got tools right now that are cheap, off the shelf, and can be helpful. But don't rely on it blindly. And you could probably say this about economic evaluations in general. Don't rely on them blindly. Pull it out in a way that enables you to scrutinize every kind of step of what's being done, how it's being done, what it's being used. Validate, validate, validate. And just remembering and finally kind of thinking about decisions here always have two kind of components, prediction and judgment's always going to require humans. Thank you very much. And apologies for stealing time.
Thanks so much, Josh. That's generating a lot of interest in the chat. We might just have a couple of questions and then come back as well. So Oliver had noticed emphasizing, I guess, some of your findings, Josh, that there was no costs associated with GPs and the cost of general practice that was coming up automatically. So that's something that someone's picked up automatically, that, there's missing pieces of the puzzle. Yeah. So that's a nice pickup. You've used ChatGPT in this instance. Did you use that for a particular reason, or like Claude or Copilot, or would you think that the results would vary dramatically using another AI tool?
Yeah, I started doing both Gemini and ChatGPT, and I was finding I was getting similar enough errors and messages. But I preferred how ChatGPT was responding to me. It was much more friendly in terms of its responses. Although when I was doing 46 back and forth to correct code, I was very annoyed with it sort of saying, I finally solved it. Now I know the problem. This will work for you. And then I'd run it and it'd still be a problem. So I got a little annoyed with it. And really, I just went back to free. I didn't want to use Copilot because I had Copilot with, which is an organizational thing. And I wanted this to be something that anybody could use free and online at the moment. I think Copilot, and especially the more paid for specific kind of levels of AI, will be much better in terms of what it's being trained on and trained for to get different results, for sure. But this is kind of your open out of the box kind of approach.
There was certainly a comment that, a lot of the time our evidence is coming from higher income countries, and that's then being used to train the responses that are coming out of our AI, which is going to introduce a particular type of bias.
Definitely.
Yeah. Okay, we might leave that there. I know that there's a lot more questions, and we can come back to those at the end. But I want to give Steve a chance as well to have a say. So Steve is a health economist, health trialist, health services researcher, and he works really at the intersection between health economics and implementation science and health policy. He's the director of two related centres, so OSHI, the Australian Centre for Health Services Innovation, and the Centre for Healthcare Transformation. He's got lots of money. He's got lots of publications. His publications have appeared in important places like the World Health Organization, World Bank, and OECD. So Steve's going to talk to us today about evidence for informing economic evaluation from his perspective. Over to you, Steve. Again, points of clarification, pop them in the Q&A and hold off your big questions for the end. Thank you.
Great, thanks a lot. I think I'm working there okay. Just let me know if there's any issue with slides. Yeah, thanks, Jean. And thanks also to Josh and Luke for really giving me a nice foundation that's going to try and springboard off that and really talk about the evidence that we need for informing economic evaluations in our current age. And also just considering sort of recent advances in trial design, implementation, evaluation methods, and causal inference. And as Josh has talked nicely alluded to, the quality of the output is totally dependent on the quality of the inputs. And so if we're making assumptions about the parameters in an economic evaluation that are not informed by actual evidence, then that's a problem. And so we have new opportunities with the advances that have been happening. I'll talk a little bit about that. I'll keep it at a high level, but we can have some more detailed discussion at the end. Just also acknowledge the traditional owners, and I'm on Turrbal and Yagara land here. So I'm just reminded before I was a health economist, I was a clinician. And I can remember my first ever research project involved 17 hospitals, and we had to get paper records that separate data collection forms. The first task though was submitting your ethics application. We had to print out 17 copies in print, and then you had to waddle over to the ethics office and deliver them in person. It was a huge effort. You didn't want to leave it to the last minute because there were about 25 other researchers at the photocopier all trying to do the same thing the day of the ethics deadline. And then when we got the data back from, say, these 17, it took us about a year to get all the ethics approvals through for the 17 sites. And then when we had the data come back in, it was actually posted, via Australia Post. And that was my job, my first job, research job as a research assistant before I'd done a PhD. I was opening the envelopes, taking out the things, and entering the data. And it just strikes me that that almost sounds ludicrous at this point, that we would be doing that. But actually, that wasn't that long ago. And we should be making the most of new situations, but you may find that we still run into some of the same challenges. As we are developing economic models and evidence to inform policy in the context of economic evaluations, the credibility and reliability of the models are directly influenced by the nature of the supporting evidence. We know that randomized trials have long been sort of the gold standard we've held up for generating evidence around clinical effectiveness. But of course, there's limitations with that. How representative are the trial participants? How representative are the tightly controlled circumstances to real life, etc. We also can make models based on observational studies or even expert opinions. They may have greater uncertainty and limit the strength of recommendations we could make, those sorts of things. Well, what about now in the digital age? Well, let's walk through this a bit. We sort of have this ongoing challenge when we're doing economic evaluations, that we're always trying to balance rigor and pragmatism. So the method's rigor ensures that we have scientific validity, but that requires high quality data, both on effects and on resource use, and how we cost that as well. So Pragmatism enables timely, actionable evidence by relying on simplified data or assumptions, making models practical for decision making. Because we've got to remember that the purpose of an economic model is not normally to do something very, very precisely. It's actually to inform a decision about how we should allocate resources, whether this is a good idea or not. And so if I'm choosing to drive home today, I may not be able to predict exactly whether I should, go to path A or path B. But if I'm 75% sure path A is going to be faster and less hassles, I'm going to take that path. And it's a bit like that with decision making in all that we do. It's not always about trying to get to a p-value of a certain threshold when we have to just make decisions about how we're going to do things. And so we're really sort of seeking to get this balance between rigor and pragmatism. And something that's interesting, and many of you online, of course, will be familiar with the increasing popularity with hybrid implementation effectiveness studies. And there's different types. Just briefly, type 1 focuses on effectiveness as the primary objective. Type 2 is a balance between the effectiveness outcome and the implementation outcome that is of interest. That could be around adoption or how far the intervention reaches, whatever the elements are. And as that relates to the intervention strategies that are used to achieve implementation in the real world. And then we have implementation focus, and that focuses more on the implementation strategies as the main outcome as the effectiveness of that. And effectiveness is still measured, but more of a secondary outcome. Now, the implication of the use of hybrid implementation effectiveness studies for economic evaluations, it's actually just probably some upsides, really, that we have useful information that can inform our effect side in terms of the clinical effectiveness of the benefit for patients, quality of life, etc. That's still usually measured. We also can measure the costs, which is really good for our economic evaluations, but also we can start to factor in some of those other elements that may be important around how we actually implement this to support reach and adoption, which may not on a single trial alone otherwise be possible in terms of knowing what parameters to use for those sort of elements. And now we're seeing full implementation trials becoming popular as well. We had an MRFF round last year where that was a stream on its own. And this is purely about evaluating adoption strategies or implementation strategies, I should say. And so there's different ways that once we know something's effective, there's different ways we can implement it in the real world. And sometimes we need to know, is this way better than that way? And how and what the implications are about that. Now, for health economists, implementation, the detail of implementation is something we've not always considered. But now that we have emerging evidence in this space, it's actually very helpful. And so this helps us to be able to make, and the implications of economic evaluations is that it can help us take this into account with our modeling considerations, help establish realistic expectations around what adoption might be like, and what sort of strategies can support that. And particularly when it comes to adoption scale and spread, which are real contemporary issues that we're trying to solve in today's healthcare system when we have interventions that have shown effectiveness. So now that we're in this sort of digital age, there's also a whole bunch of newer approaches that we've seen come to light. Some you'll be familiar with already, but I'm just going to cover through, this is a really sort of 1,000-foot view, 10,000-foot view of some of these considerations. So digital maturity that we're seeing in health services can certainly enable efficient collection of real-world healthcare data to complement traditional clinical trial methods, evidence from clinical trial methods. But there can be some challenges with real-world data. Is it very has it been standardized in its collection? Is it reliable? Has it been verified? You just think of any electronic medical record you've looked at. Think about how sure you are that all of the entries in there are accurate and true, relative to tightly controlled randomized trial where someone's focusing on collecting that data. Now, it's not to say it's not useful, but there's just some considerations around how we deal with that and how we manage that. Similarly, digital mature systems support innovative methodologies for generating evidence using sort of new tools and new analytics. So we can have new data. We can also use different styles of analytics to support that. But there's also some challenges, like well, who's actually going to do that? Who's going to get the data out of the back end of the system so that we can run those analyses? And who's going to run those analyses? Because health services generally are focusing on delivering care, and it's still an emerging space where we have data scientists, for example, that are able to think of these things in the context of research, not just core business of delivering services. And related to that actually is the way that what data we analyze and how it's governed. That's also a really contemporary challenge as we get into higher levels of digital maturity, is how we are governing complex healthcare data, and also what's the social license for us to be actually using this information for these sort of purposes, because we don't want to go beyond what our community would appreciate this being used for. And so that's an important consideration while we're considering governance of how we go about using these routinely collected data in digital health systems. We also just want to think about the decision-making cycles are getting faster, and especially as we have new interventions becoming available, and high levels of digital maturity can enable prompt assessments of cost effectiveness using real-world evidence, and that can improve decision-making, but actually getting that done in a prompt way within resource-constrained environments is also challenging. And so just to quickly summarize some of those things, there's some really good things, like strengths is that we have enhanced data richness. Some of the challenges are that, and also we have continuous capture. That's also sort of new. We have weaknesses in that there's some heterogeneity, and then there's good data standardization models like OMOP that are becoming sort of more common, but that's still a ways off in many cases. There's opportunities to use analytical techniques that we haven't necessarily used before, and Josh touched on that a bit as well. If you thought of his hierarchy of complicated from very basic approaches through to complex approaches, and even getting down to event simulation and agent-based modeling, when we have high quality and digital mature sort of organizations, those things become more feasible. And just also to be mindful that our traditional frameworks really starting to lag behind what's needed to make resource allocation decisions and policy recommendations in real time. There's no longer we can think of an idea, we can wait, we've got 12 months to apply for a grant or something, it takes us 5 years to do the study, then we're publishing the papers, and so 6 years from now we're going to have the answer. If that's our approach for economic evaluations for policy relevant sort of findings, that's probably not going to work. We need to do, and we are already doing things that are much more contemporary in terms of coming to solutions more quickly. All right, so I might actually, just in the interest of time, mindful we are moving on, there's also some new trial designs. So you would have heard of, let's go here, sequential multiple randomization, or SMART designs. So this is where individual people receive more than randomization depending on whether they respond or not. So that's really interesting. I'm just wrapping up an economic evaluation for one of these at the moment. Interesting to do. And this can be used in things like chronic disease management, behavioral interventions, and so forth. You'll have heard of adaptive platform trials. Again, these are really came alive during COVID, but we're seeing them expand. One take-home message is that they probably only seem to be really effective or really cost-effective to run if you're actually going beyond 2 arms and having multiple stages. Once you get to the multiple stages, all the extra work at the start setting up pays off. But unless you're getting beyond the first comparisons, then the extra work may not be worth it. The implications from some of these sort of adaptive trials, well, it actually aligns pretty well with the way we think in terms of health economists and Bayesian frameworks and things, but they do require greater planning and more advanced modeling requirements. People need to be aware of confounding risks, including usual care drift, which can happen in platform trials. And then lastly, just understanding that have some awareness of target trial emulation that's becoming popular as well. So target trial emulation is essentially an observational study whereby you can specify what you're going to do and set it up in a way that it mimics a randomized controlled trial. And this is possible when you have really large data sets and access to real world evidence from medical records, for example. So there's some really good things about this, but again, we need a certain level of sophistication in the analysis and the capability of the workforce to enable this to happen. But it's coming, it's here. We're already starting to use it, but it's only going to grow from here. So just and to enable a few minutes of talking from the panel point of view, I just want to flag that while we have come a long way with all these things, I'm reminded of some work we're doing at the moment around federated learning, where it's actually taken us more than 2 years to get the agreement signed because people don't understand what we're actually doing. And so while we thought this would be an advancement because people can leave their data where it is, we don't even need to access it. We can send our model in to use the data that's there, and then we just get the answers back for the analysis. That just sort of blew the minds of the people who were signing off on things. So it's actually taken us longer than it would have been if we just extracted the data and linked it. So anyway, interesting times and yeah, open to discussion. Thank you.
That's great. Thanks so much, Stephen. Keep your questions coming in. We've got a few there already. I just want to kick off with an easy one for you, Stephen, before we let you go. You've talked a lot about how we're actually incorporating the economic evidence in with trial evidence. What, in your opinion, does a successful collaboration look like between a non-health economist and a health economist working together to solve a problem? What elements are required?
Yeah, sure. Yeah, I can take that probably from both sides. Having formerly been a clinician and then sat on both sides of the fence, my big tip for everyone is do it together from the start. That's the big tip. If you're thinking of doing a trial and you're thinking of doing an economic evaluation, find a health economist that can work with you from the start to do it well. If you're trying to do it and retrofit at the end, it's hard. In Queensland, and we've got some really great health economists across our various groups. We all get along with one another. We're friends. If we can't help, someone else might be able to. But I can say that we all care about doing good economic evaluations. So yeah, my big tip is speak to someone early and then do it together.
That's fantastic. Thanks so much. I might throw over to Luke. Luke, this one looks like it's got your name on it. So Oliver asked, what do the speakers think about Australians being unable to insure privately for the costs of out-of-hospital care? This prohibition was introduced by the Hawke Labor government. Should it be repealed? Oh, you're on mute.
Yeah, one of the things that like from an economic viewpoint, one thing that motivates that type of prohibition is actually trying to limit the effects of moral hazard, which might actually then lead clinicians, especially specialists who are not facing a lot of competition, to ratchet up prices, knowing that patients are largely immune from those price increases, or at least only pay a small amount out of pocket. So I think that it is a peculiar arrangement in Australia, nevertheless, and it would be worth looking at to allow people to have those out of hospital costs covered in perhaps some limited way that doesn't put too much upward pressure on price.
Fantastic. Thank you so much. Going back to economic evaluation for a moment, there's an anonymous question about the use of your intended use of AI in a clinical trial or in subsequent economic evaluation. Has anyone yet written that into an ethics application? And if so, how's that been received? JB?
Yeah, I haven't seen it myself. At the moment, I would say people are using it more as a co-pilot, like I'm going to do it and then get some help as I like. No one's been too explicit about that. I know there are various reporting in general for publications, but I haven't seen it in ethics about the use or how people are using AI. I think it does open the door to just the broader risks of AI, which I didn't really touch on. So once it's this kind of classic idea of if these kind of digital tools are free to use, then you're more likely to be the product than the consumer. And so if you're thinking about uploading data, sensitive information, sensitive data into these kind of open and free kind of platforms, stop it, don't. And I don't think you need to kind of ask ethics to know that is not what you should be doing, because that is now releasing data into the world for other people to use that probably shouldn't and would be an ethical breach.
Yeah, thanks so much. Steve, did you want to add to that?
No, I'm actually answering one in the chat. So I actually,
Okay.
missed. I don't want. I'll
I'll
probably
leave
just
you to
repeat what Josh just said.
concentrate.
Yeah.
I might ask Josh another one then. Joanne was just questioning Josh about what you meant about in ChatGPT or Chatty G, as I like to call it, about Starter not being as natural to use to ask for code compared to something like R. What were you actually getting at with that comment?
Yeah, so Stata's a statistical software package, and it's a package you've got to purchase. And even though it's got a lot of free and online kind of help for code, it's still kind of what you might call proprietary kind of code or things like that. ChatGPT and a lot of those programs are actually using Python or other sort of forms of code. And I just asked for Stata code because I can read Stata much better, so I could kind of debug what was going on. But ChatGPT really struggled producing Stata code that actually worked. I'm betting that if I asked for Python, it would have worked with far fewer issues, just because it's natural. And I think R the same because R's are completely online, and so it would have had a much better source of free kind of online code to kind of populate its answers to. So it was really just me kind of going, there's a lot of bugs in this code, but it could be because Data's proprietary kind of software.
Yeah.
That's great. Thank you.
I can
Yep.
just to comment on that as well. Just I find it's also buggy with R and Python both as well. But it depends, yeah. But I think it almost feels like the changes between upgrades sometimes between the different models and also across Copilot, Enterprise versus some of the others as well. In the end, you still got to know what you're doing to be able to troubleshoot and decode it and recode it. Yeah,
and 100%. That's like, ask for what you're familiar with because you're the one that's got to be able to understand it and unpack it.
Yeah, perfect. Yeah.
Well, that's very bad news for all the budding PhD students who want to substantially reduce the time to completion. But a question for all panelists now. We probably only got time for one or two more. Why is it that we don't see health economists in hospital settings so that they're more easy to access and more visible, considering their valuable inputs, and how do we get to them early? Who would like to answer that? Luke, would you like to make some comment?
Yeah. Look, I mean, we do venture into hospital settings when we're invited to. So I think as well, maybe the whether there's not many of us anyway to start with, and then second, maybe the use of health economists in hospital systems is probably sort of it's maybe underappreciated what can actually be done by an economist to help with the efficiency of running a hospital in conjunction with a multidisciplinary team. So they would be my guesses, but maybe Josh and Steve have something more to say.
Yeah, look, I think I worked in a hospital for 20 years, so they are there. I was, and still am actually, to be honest, not almost all, but a very high proportion of my work is embedded still in hospitals, one way or another. The challenge comes with resourcing that. So that's why we always need to just make sure that because I only have so much time, of course, and so we have a big team of other people as well. But for each of them, they've got to have a salary from somewhere. So that's the challenge, is just finding how to resource the time, because some of this stuff can take a bit of time for people to do well. Yeah.
And they're not keeping you in a special bunker in the basement or anything, Stephen?
I used to be actually, I was very close to the basement for a little while. In the mid 2010s, I think I was near the basement. Yeah.
Look, I'm really sorry. That's all we've got time for today. We've come to the end of our time. We've still had some more questions, and I think if our panelists have a moment to be able to answer those online, we'll give them that chance. But thank you so much for a really interesting session. We've covered a lot of different ground. Reach out to a friendly health economist. Go down to the basement of your hospital and look for one down there if you can't see one on the ward. But we look forward. Thank you very much to HTQ for supporting this today and actually bringing a lot of the issues around health economics to light. Sue, would you like to make some closing remarks?
No, just similar to what you've just said, Jean. It's been really interesting presentations. Certainly got me thinking. I think from a hospital and health service perspective, it would be great if there was funding to support in-house health economists within the hospital and even primary care settings, just to get that better interoperability between the way the systems work. So, thank you to each of you. Really appreciate it.
Thanks so much. We'll let you all go and have a good time this afternoon. Okay. Thanks so much. Bye-bye.